My name is Dr. Muchai Gachago. I'm a consultant ophthalmologist and vitreoretinal surgeon working at the City Eye Hospital. And it is my pleasure to present at this third annual OSK Scientific Conference. I'll be talking about giant macular holes, that there is yet hope when it comes to this particular disease. I will discuss the classification of macular holes very briefly, and then I will talk about the surgical approach to giant macular holes, and then discuss a few cases. We shall look at a few fun images and then see what our learning points are at the end of it all. So when we look at macular holes, there's the original gas classification. And there are stage 1 holes, which are basically impending macular holes, where all you have is a yellow spot or a yellow ring. We then have stage 2, which are small, full thickness macular holes, which are less than 400 micrometers in diameter. And then we have stage 3 holes, which are full thickness macular holes of over 400 micrometers without vitreous separation, and stage 4, which are holes larger than 400 micrometers with complete vitreous separation, as shown on the OCT images to the side of the screen. Now, as we discuss giant holes, we shall be discussing holes that are above, way and above these 400 micrometers, and we are talking about holes which are more than 800 micrometers in diameter. So the surgical approach to macular holes is basically doing a pars plana vitrectomy for full thickness macular holes. This is a hole which is stage 2 and above, and then doing an internal limiting membrane peel. This has been found to increase the success rate of hole closure. As you can see from the image shown there, that's an ILM which has been stained with brilliant blue, and then injecting gas, which can be either SF6, C2F6, or C3F8 gases. And this enables tamponading of the hole with better hole closure. For giant holes, these are holes over 800 micrometers, you have the option to do nothing or to do something. Doing nothing came from discussions that were had at the African Retina Society meeting of 2018, where it was found that there was little in terms of vision gain for giant holes before and after surgery. But from Afro-German Eye Network meeting of 2018, the same year, it was established that doing nothing led to progressive deterioration in vision. And I have seen the same from my limited personal experience, seeing that from year to year, in as long as you did not operate on these eyes, you got a gradual reduction in visual acuity. So there's something that you can do beyond the regular surgery is an ILM flap if surgery has not previously been done, an ILM graft if surgery had been done and an ILM peel was therefore already done, or doing an autologous serum into the macular hole, or doing a free retinal graft. So we shall look at a few cases where I did an ILM graft and see what the outcome was. So the first case was PW, a 60-year-old female nurse who complained of poor vision in her right eye. She had had previous vitrectomy for her right eye, having had a macular hole, and it had failed to close. On examination, her visual acuity was, counting fingers, 1 meter in the right eye without improvement on pinhole. The left eye was 612, improving to 6.9. On fundus examination, there was a full thickness macular hole with temporal retinal scarring. OCT showed a large macular hole of 1,470 micrometers at the base. We did fundus autofluorescence to establish the health of the retinal pigment epithelium, and it appeared to be in a good condition. And therefore, we thought that doing surgery would be beneficial to this patient. So we did a pars plana vitrectomy, ILM graft, and SF6 gas injection. 1 month post-surgery, this is what the OCT looked like. The hole had closed, and although there was a thin reconstitution of the foveal architecture, the patient was quite happy. We did a Feko Plus intraocular lens 1 month after vitrectomy, as the patient had a significant cataract, and the final visual acuity was 660, improving to 648 with glasses in the right eye. The patient reported improved vision, reduced scotoma, better reading ability, and better functioning at work, and she was happy. The second case was TO, a 60-year-old female administrator. She complained of poor vision in her right eye. She had had previous vitrectomy for a right eye macular hole in 2019, also with failed closure. On examination, visual acuity in the right eye was 260, not improving with a pinhole, and to 624 in the left eye, improving to 6.9. Anterior segment revealed a cataract. Fundus examination revealed a full thickness macular hole as shown below with a base of just over 1,600 micrometers. So we started with a cataract as it was significant, and we did Feko plus intraocular lens and a guided visual prognosis because of the hole. Then COVID happened, and 8 months later, she was able to come in for vitrectomy, and we did a pars plana vitrectomy, ILM graft, and SF6 gas injection. 1 month after the surgery, as you can see from the OCT below, the hole was closed. Again, very thin restoration of the architecture of the macula because of the original size of the hole. But when we look at the visual acuity, despite the hole closing, the visual acuity remained the same. However, there was a subjective improvement in vision. The patient was happy, but when you told her the visual acuity had not changed, she said that she actually felt better. And this was because largely the scotoma, the dark spot at the center of her vision, was gone. And so we are finding that with closure of the hole, despite abnormal architecture and not much in terms of visual acuity gain, the scotoma goes. And therefore, the patient is actually better to read out of the other unaffected eye. She had better reading ability, therefore, and better functioning at work as an administrator working several hours on computers and documents. And she was therefore happy. Now, we shall look at a few fun images, but of course, related to our topic. So in cases where you do an ILM flap for these large holes, as the case shown below, sometimes you get poor integration of the ILM into the hole. And as you can see, the image on the right, you can see that after surgery, the hole kind of opposed, became more of a V shape as opposed to the larger original hole, but you can still see the ILM just dangling there, hanging over the hole. In other cases, you have the hole closing with integration of the ILM flap or graft. However, you find that there isn't a restoration of the normal foveal contour. So you can see this patient here had a mound that formed at the fovea instead of the usual depression that you get. So sometimes you don't get what you're expecting. And so you have this kind of closure of a macular hole with an ILM flap. In some cases, you then get almost normal restoration of foveal architecture. And in this case, you can see a hole we did with a macular hole base of 997 micrometers, coming to almost normal foveal contour. The outer layers of the retina are not fully reconstructed, but at least you can look at that and know it is a fovea. This was an OCT done 1 year post-op. So what are our learning points from these cases? That one, a candid conversation before surgery with your patient is most important. This will help you manage expectations. And in these cases, you must promise low and try your best to deliver high. And then patient satisfaction can be achieved if you take these steps. You can have improved function in terms of visual acuity gains, reduced scotoma, improved function, improved reading ability. And you can take your patient off the slippery slope up the Snellen chart, where your patients are reading progressively worse and worse with every passing year. Thank you very much.